Good afternoon, everyone. You're very welcome to today's HSE Health Regions Supporting Teams for Integrated Working. The panel would be delighted to receive any questions you may have, so please use the Q&A feature located at the top of your PC or laptop screen. And if you're using an iPad, you'll find this feature located at the top of your screen. Please take a moment to share your response in our Menti today. So if you go to the website www.menti.com and input the code 13246267 or scan the QR code on screen. And without any further ado, I'll now hand you over to your host, Liam Woods. Thank you.
Good afternoon, everybody, and welcome to the Health Regions webinar series. My name is Liam Woods, and I'll do some introductions. But the agenda for the webinar is as follows. I'll do a brief update on Health Regions, and then we'll move on to Lisa talking about the integration tools and resources to support integration, and then Michelle and Veronica to look at experience in using the integration tool. And leadership competencies will be addressed by Mary O'Kelly, IHA Manager, and Dr. Kira Martin. And then we'll come back for a panel discussion. The items will be pre-recorded, but the panel discussion is live. So I'll go on to my presentation. In terms of the objectives, the first objective is give an update on Health Region implementation, and then provide an overview of integration tools and resources, followed by sharing learning from a lived experience, and then to explore leadership competencies and signpost key resources and supports. And as I've said, at the end, there will be a Q&A, and we can engage in that. Just briefly then, in terms of the vision for regions, and this is Sláintecare from 2017, and remains the vision, very much person-centred, informed by needs of people and communities, coordinating care closer to home, so aligning hospital and community for that purpose, continuing to focus on national standards, but also enabling greater local decision-making, recognising that that's a critique of the HSE, that decisions can be overly centralised, and ensure there's a strong focus on access and quality care. And also to improve health and well-being. Sláintecare was very strong on improving health and well-being and on fair allocation of resources. And we've invested significantly in that in terms of public health medicine since COVID. So the objectives are align and integrate hospital-based and community-based services, clarify and strengthen governance, support a population-based approach, and improve equitable regional investment, as well as running efficient and highly productive and transparent health and social care services. And they're the objectives, as I was saying, straight from Sláintecare. They're the guiding objectives in terms of all the work we're doing on HSE structures and HSE reform at the moment. And just briefly, in terms of what's decided, the 6 regions set out on the map have been created, and indeed the subdivisions of those into 20 integrated health areas also mapped, and recruitment having taken place for those posts. The health forums will continue to exist. There will be 6 instead of 4. They include representation from local councillors to give an input into health. And the groups and CHOs as of last October 1st have been stood down, and the new structures for integrated health areas stood up. The centre, the HSE Centre, is also changing, and its role is moving to more planning, enabling, performance and assurance, and so not operational, with a couple of exceptions in areas like screening and indeed PCRS and National Ambulance Service. So the vision of Sláintecare is very much building care around people in communities at home, with support from increasingly specialised services and ease of movement across services. We recognise, of course, the structures on their own won't deliver that. This is about people providing services to patients and service users. And so from our point of view, while we're focused on structure, today's session is very much about considering tools that enable integrated care delivery and focusing on that. And the timelines we're looking at are really through to the 3rd of March to implement the next phase of change and put in place the final structures underneath the integrated health area managers, and so align the whole system into common geographies with a very much a population-based focus, which was key to Sláintecare. So we've moved from an environment then where we have separate organisations running acute and community care to having joined up management of those services. with a view to supporting and enabling the delivery of integrated care, but recognising there's a journey ahead for that. And now we'll go to Anne Lawler, Chair of the HSE National Patient and Service User Forum, for some comments on patient and service user perspectives on integrated care delivery in practice. And the video links for this clip will be put up on the website and in the chat. And then we'll go immediately to Lisa to talk about the Sirocco tool. Thank you.
This is so exciting. I know it's a daunting prospect, and I hear the questions and I hear the unanswered questions and all of that, but this is so exciting. And what's so exciting for me is to see the patient partnership coming into the picture. I would agree with Karen, in lots of ways we aren't there, but the patient partnership thing is crucial. It's not crucial, maybe not for the same reasons that Karen might think, but I think it's crucial because there are many people on this stage here, various expertises, and patient partnership is just another expertise. So it's my lived experience that taught me about integrated care, and I've always said it, and congrats to all you folk who put them posters together. They are amazing. They are absolutely amazing. And I've always said the people with the problems will invariably have the solutions. And that goes for the frontline care workers who do that marvellous work. They work with these people and they know what the needs are and they're told what the needs are and then they go and do something about it. But it's so important to get the consistency across the whole way.
Thanks, Liam. I am delighted to be here today. So to start, you may have noticed that you were invited to join a Menti poll to share what integrated care means to you. And this is because integrated care can mean different things to different people and is shaped by a range of perspectives depending on your role, experiences, and most importantly, the healthcare context that you work. So I'll be really interested to hear your responses of what integration means specifically to you. So integrated care is a complex and evolving concept. In fact, a literature review in 2009 identified approximately 175 definitions of integrated care. But in the report, What is Integration?, Shaw et al. Outlined 4 key lessons that can serve as guiding principles for anyone pursuing integrated care. So the first is integrated care is best understood as a strategy for improving patient care, where the service user is the organising principle, and that one form of integrated care does not fit all, and it is only possible to improve what you measure. So Liam has presented the slide, which illustrates the Canterbury model for integrated care. The model places the home at the centre of the healthcare system, with the hospital positioned on the outside. And this is a vision that aligns very closely with what we are trying to achieve through Sláinte Care. And it does represent a fundamental shift towards person-centred care, where services are designed to support individuals in their own homes and communities. And the hospital is the last resort rather than the primary focus. So a really useful report is the Blocks report, and it was titled Tools and Methodologies to Assess Integrated Care in Europe. It was developed by the Expert Group on Health Systems Performance Assessment, and it was published by the European Commission. The name Blocks symbolises the building blocks required to create and measure integrated care systems. So the report is very useful because it emphasises practical tools designed to assess key areas such as patient outcomes, care coordination, and system performance, which are really critical elements for advancing integrated care. The report also identifies key building blocks, or what they call systems levers, that are critical for creating effective integrated care, and it highlights that there's 11 key elements that contribute to their success. So these principles and success factors are closely interconnected and are shared across integrated care experiences in Europe. So you can see the 11 key elements on your screen. So integrated care is complex, It is multidimensional and it is almost as complex as the needs of those that it serves. The transition to integrated care is a complex process with high complexity evident in every aspect of design, implementation, and assessment of integrated care. So given that integration is often messy, it's complicated and complex, having the right tools to guide and support the process is really essential. So we have identified 4 key evidence-based tools that address integration needs at multiple levels. So at a team level, at a service level, at an executive or more management level, and at a systems level. So the tools will help assess readiness for integration and support the journey towards more coordinated integrated care. So in order for us to make these tools practical and relevant for teams in Ireland, we are adapting them and we're developing support such as workshops and guidance materials. And over the next coming months, we'll be providing more detailed information about each tool and also how you can access these resources. But for now, I will give you a brief snapshot of each tool just to give you a sense of what will be available to you and how they might support your work. So this is the SKY logic model for integrated care. It was developed by the Social Care Institute for Excellence, known as SKY. It is a logic model, so it is designed to help teams plan, implement, and evaluate integrated care initiatives by offering a clear roadmap to align resources, actions, and outcomes. The logic model is really useful because it is a visual description of what good looks like, showing how a fully integrated health and social care system might be structured, but also how it might function. It outlines the key outcomes and benefits that it should deliver for those who use the services and their carers. So it describes the key enablers of integration, the components and the activities of integrated care, while also describing the outcomes for those who use the services, what outcomes it would be for the integrated services, and also for the wider health and social care system. So stakeholders who were involved in developing this logic model suggested that it would be a useful tool for local planning and performance monitoring. So it is a very valuable resource for integrated care efforts at a team level. The next tool is more aimed at a service level, and it is the Integrated Practice Assessment tool. So this is a practical resource. It is designed to help teams assess their levels of collaboration and integration. So it is based on the framework outlined by the Standard Framework for Levels of Integrated Healthcare, which was released by SAMHSA, the HRSA, for Integrated Health Solutions. It is a framework for understanding integration as a continuum and defining the stages of integrated work. And so the IPAT uses a decision tree model. So it guides teams through a series of yes and no questions to identify their position on the integrated continuum. So you can see on the left-hand side, is it minimal collaboration or is it full integration, which is the right-hand side of the resource. So it's simple, but it's actually a really effective approach, and it helps teams to evaluate their interdisciplinary practices, pinpoint areas for growth, and plan actionable steps towards more cohesive and integrated service delivery. It is a really useful tool because it prompts reflection, alignment, and meaningful discussion amongst teams at a service level. So now at an executive level or a management or a team kind of level, we're looking at stepping up to the place. It is a self-assessment integration tool, and it was developed collaboratively in the UK by the Local Government Association, the NHS Confederation, and the NHS Clinical Commissioners. It is specifically designed to help health and social care leaders critically assess their progress towards integrated care, and it focuses on key areas such as shared leadership and effective collaboration. It encourages honest reflection on the strengths, but also areas for improvement in local systems. And it is a very practical framework because it provides clear prompts to guide discussions, but it also helps leaders align their efforts within the shared goal of improving outcomes for both individuals but the wider community. What makes this tool particularly valuable is its ability to create a shared understanding amongst service providers, and this shared perspective fosters collaboration and supports prioritization of actions needed to advance integrated care. And the last tool is Sirocco. So the Sirocco is an online self-assessment tool. It was designed for the adoption and scaling up of integrated care across regions and health services and systems. So it was developed from the maturity model for integrated care by B3 Action Group of the European Innovation Partnership on Active and Healthy Aging. This tool evaluates a system's readiness for integrated care by examining 12 essential dimensions. So you can see the 12 dimensions on the screen on the left-hand side. It has been validated and tested in over 71 regions and organisations, and it is available in 9 languages. But what makes the Sirocco tool particularly practical is its use of a spider diagram. So you can see that on the right-hand side to create a visual map of a system's maturity levels across the 12 dimensions. So it is a very visual representation, and it helps teams quickly identify strengths, gaps, and areas for improvement, which just helps make it easier to prioritise actions and allocate resources effectively. So to bring this to life, we will now be hearing of a team who has used this tool in practice, and they will be sharing their experience of interdisciplinary working in a question and answer session. So we are joined by Michelle Grogan, Senior Social Work Practitioner, and Veronica Hennessy, Senior Physiotherapist from the Posture team. So firstly, good afternoon, ladies, and thank you for being here.
Thanks, Lisa.
Thanks, Lisa.
So firstly, we'd really like to hear more about the Posture team. So can you tell us about who's involved, where you're based, and what kind of work that you do?
Yeah, thanks, Lisa. So we're the Posture team, and we're probably best described as an interdisciplinary paediatric primary care team. We currently have 2 teams in operation, and we're based in Kildare and in Tala. The Kildare team covers 2 networks, and that's Network 11, which covers Newbridge and Kildare Town, and then Network 11 covers Athy. And then we have 2 teams based in Tala as well. Sorry, a team based in Tala covering 2 networks also, and that's Network 8 and 9. We're made up of a number of children's healthcare professionals, including psychology, speech and language therapy, physiotherapy, occupational therapy, social work and dietetics. I suppose where did it all begin? The Posture team was established in 2022, and it was trialling a new pathway for service delivery for children in primary care with multiple needs. I suppose there was a clear appetite at the time among management for change. They could see these challenges as well within the paediatric services. There are many children attending primary care services whose needs are really appropriately and really well met in a unidisciplinary manner. But I suppose we also know that the profile of children that are attending primary care has really evolved and changed over time. And like children are attending with the multiple needs and require that more team approach to, I suppose, understand the needs and to better understand the needs. And I suppose that's where the idea of the Posture team was born. I suppose how are we different? We're different to our primary care clinicians and team, I suppose, in given that we work in a team-based approach with our families and our children on identified goals. We're a time-limited service, so we work with families as well for 20 weeks. And in that 20 weeks, it's our hope that we get a better understanding of the child's needs, and I suppose support them to be able to manage those behaviours and those needs better, while also supporting the families to more successfully engage with our primary care services in the future as well. Also, our referral process is different as well. Our referrals only come from our primary care colleagues who know these children either from their open caseload or from their wait lists, and they know they feel that these children require that team-based approach. I suppose where we are now, we're 2 years into the process. We've got lots of data and feedback to, I suppose, show that it works. When you look at things like the cost and I suppose the long-term implications on our health service. From a team approach, we really feel while working in it, it works and it makes sense. And I suppose it's our hope that there's more of these teams, expand over time, because we can really see the benefits for the health service, but also the families we work in. But we're under no illusions. We know that integrated care and integrated working doesn't come without challenges, and it is difficult and it's not easy. But I suppose we're hoping that our team could maybe be a blueprint or some sort of blueprint for more integrated services for children. I suppose we used the Sirocco tool Veronica introduced to us as a way to kind of reflect on the work we've done, and we kind of found that was really helpful when we're looking at our integrated working.
Okay, so Veronica, Michelle was just saying that you had, introduced the Sirocco tool. So can you give us a bit of background as to where you came across the tool and in what context, and then why you decided to use this within your team?
Yeah, sure. I had a great learning opportunity. Last year, I completed the Principles of Integrated Care course. It's a postgrad certificate down in MTU. And I also attended more recently an OECD meeting, which was a kind of a project meeting between the Department of Health and the HSE, I suppose, in identifying ways of planning integrated care and helping stakeholders understand the three main areas of focus for integrated care. And the Sirocco tool was introduced as a way of doing that. So looking at the local context and conditions for delivering care, as well as the readiness for change, and the strengths and weaknesses of an organisation to either adopt or scale up. So that was where we first came across it.
So for kind of our listeners, would you be able to talk us through the kind of the practical approach that you took in terms of using the tool?
Yeah.
What was the process like?
Sure. As you mentioned, Lisa, earlier, there are 12 dimensions to the Sirocco tool, and each dimension is rated between 0 and 5. Just share on our next one. There we go. So each dimension is measured between 0 and 5. And there's a description to each of those levels that you might choose. So myself and the team, we literally sat around the laptop. It's an online assessment tool, and we kind of discussed through which level we found our services at the moment. And the rationale for each of those areas. So it results in this kind of spider type diagram, it's really effective and visual, as you said. To just give an example, the first one there at the top of the screen, readiness to change, we rated ourselves as a 3, and that's where there is a vision or plan embedded in policy, and there are leaders or champions emerging. A 0 for that would be there's absolutely no acknowledgement or compelling need for change, and maybe a 5 for that would be there's a political consensus and there's a public support to change. So there's a big gap between 0 and 5. So, we kind of reasoned ourselves out that we were at a 3. It was really good for us as a team to reflect on the context of our service delivery so far, looking at the strengths and weaknesses more so from our local environmental level rather than maybe region or national level, which, is useful as well, but that we can do everything we can within our circle of control. So that micro, meso and macro level viewpoints can be put on top of our own one, and seeing whether there's common areas of recognition, but also common areas of maybe areas for improvement where there's maybe difficulties or struggles in terms of barriers for integrated care. So if similar scaled projects and teams use the same diagram, it could really recognize those early adopters to change, as well as the common areas for challenge.
So speaking of those areas of challenge, what did you find out from using this tool were your main barriers in terms of integrated care?
Yes, I suppose if you're looking at the web, digital infrastructure was one of probably one of our more significant ones. I suppose at the moment we've got no current digital pathway for referrals or for sharing information with our primary care colleagues, which obviously would make life a lot easier. But we know a lot of work has been done nationally around this. But however, I suppose it hasn't filtered down to us yet on a practical level. I suppose that we know the 2022 digital survey was done, and that showed that Excel was used a lot for managing data, and that's how we do it. But I suppose other applications are available as well, but of course they're just maybe not available to our team as well at the moment. Our colleague Karen Young, who's our speech and language therapist, seen this gap as well I suppose within our service, and developed a timeline tool to try support our team to work more efficiently, and that really worked. Is in that where we became more efficient, and it was 15%, and it really showed that really small change can be really impactful on the service, and I think that would be really helpful, I suppose. But again, we find it really hard to get that digitalized, and I suppose that would be something as well. Again, maybe would help other MDTs in the future as well. So just small things cannot make a huge change. Other things we looked at is staffing. Again, we know that's a resource that's not just an issue for ourselves, but I suppose when we think about a more integrated working, we're feeling we need staff across primary care and the POSHA team, as in it doesn't work if there's no staff to send over the referrals, or again if the staff vacancies within the POSHA team as well. It just I suppose it inhibits the processes and the the moving on of the team as well, which is really important. I suppose what we've looked at as well is things that, we've heard lots of things about to be integrated, you need to share. And I suppose it's really hard to share when resources are people are under pressure for resources. And we do know, and it's really evident, that lots of people become a little bit more less likely to share if they're feeling the squeeze about resources, because they're afraid they might get it back, or they'll be gone forever. So it's all of those things that definitely impact on our barriers for, I suppose, moving integrated care on.
So on the flip side, let's move to the positive. So what were the strengths that you found that you're doing with the team? So what's working really well in terms of the pasture program and the pasture team?
Yeah, so definitely, again, you can see the innovation management was quite high there on our radar as well. We found this way of working it really has created a pathway for managing and working with complex cases in primary care that wasn't there before. Our primary care colleagues now have somewhere to bring these cases that that require that team input, which is, I think, is quite innovative for primary care. I suppose we put a lot of thought into the how we could integrate into primary care and to get our colleagues to buy into our service, because we understand that change is really difficult for lots of people, or for everybody. I suppose the structure should allow our primary care colleagues to feel invested in the POSHA team, as they as clinicians decide what children come to the POSHA team, and they also decide who should be prioritised in what order. So I suppose that we're hopeful that definitely helps the innovative way of working as well.
And another strength of ours, and you can see from the diagram, our strongest is probably the capacity building dimension. And again, basing it on our more local level, it's looking at a person-centered learning healthcare system involving reflection and continuous improvement. And we're constantly trying to evolve our service here. We're constantly reviewing our standing operating procedures, our referral care pathway, and taking on board the feedback we get from our primary care colleagues, and trying to adjust as much as we can. So like I say, a broader outlook from a managerial level may score that differently, and neither of those answers are wrong. It's just informing from those different levels.
So what I find really interesting from your radar diagram is that you seem to have scored highly on evaluation methods for integrated care. So could you tell us a little bit about that? Because I think people would be quite interested in that.
Yeah, well, as most people will realise as they get into integrated care, it's hard to measure. And look, we're a new care pathway. It's hard to measure a new service in the kind of pre-existing neat boxes of KPIs that maybe a unidisciplinary service might have. And they have their purpose as well. But I suppose as long as we're ensuring that we're looking at the quality of care, the cost of the care, the access, and in our position, I suppose the child and family experience, those are the things we're going to try and measure a little bit, or a lot. But I suppose we're collecting lots of statistics on quantitative and qualitative data that we have. And we found that a child who comes in from maybe sitting on 3 or 4 primary care waiting lists, and they come through our cycle of care and they go back and maybe sitting on maybe just one, well, that's a huge measure of our input, and a good indicator of measurement. Children, in general, they're going back on at least a third less primary care waiting lists. An actual over 60% of children that come into our care or into our program and cycle, 62% have an unidentified need that maybe wasn't recognised already. We then meet that need and, I suppose, prevent a further referral to another primary care service by the time they finished with us. And over 90% of parents feedback that the most important thing to them is that they have a greater understanding of their child's needs going forward.
That was a key outcome for you, and that made a huge difference in terms of how you approached and thought about measuring integration. So just listening to the both of you, you have a wealth of experience and expertise now developed in integrated care, and particularly in interdisciplinary working. So what nugget would you give to people listening that they would do? So what key kind of advice or nugget would you give to other services to start working on integrated care?
Yeah, so I suppose the main thing, I suppose, that have become really obvious, as most of the team within the post team came from unidisciplinary work, and so are well aware how that works as well. But I suppose the positives here is the shared learning. We're all in the same office, so I suppose the shared office offers that debriefing directly after after a session where team members can discuss and can, I suppose, case formulation occurs, and we can do joint work in much more easy, much more opportunity as the opportunity arises, where you know, two clinicians are in a session with a child, and education and with a parent or modeling can happen. I suppose it's all of those different high level of therapeutic coordination that can happen, I suppose, or collaboration. Other things is the cutting the lag time, I suppose, between the intervention and assessment of different disciplines, because we get to have those conversations outside of the waiting for a clinical team meeting or a more formal meeting. And then I suppose the co-location with our primary care colleagues within the primary care centres, where those informal chats or those informal discussions happen, again, outside of those more formal times or meetings. And then I suppose just building that rapport and the relationship with our colleagues as well is so important. Like anything to work, you need to have good relationships and communication, and that really works when you're working alongside or working co-located with your colleagues, we think.
So it's a key piece, which is about investing in the soft skills as well as the hard skills. So being able to invest in building trust, relationships, and getting to know colleagues to be able to make that process a lot easier. And small things tend to make a bigger difference.
Yeah.
And Veronica, what's your key nugget that you would like to give to staff that are listening today?
Well, like as Michelle said, it's communication, and it's, I suppose, clear communication down from different levels. So, you know, cross communication between different primary care teams, and on then, I suppose, from, you know, operational leads, management level as well, is that the clearer and more simpler it is, the easier it is for change to, I suppose, to be received and accepted. And that's a huge part of it.
Thank you so much to both of you for sharing those really valuable insights and experiences. So next, we are delighted to welcome Dr. Ciara Martin and Mary O'Kelly, who will be discussing the leadership competencies needed to deliver integrated care. Thank you.
Thank you, Lisa, and good afternoon, everybody. So leadership competencies to deliver integrated care, it's a huge topic. So today, Dr. Ciara Martin and I are going to give a brief overview of operational and clinical leadership competencies and share some of our learning from a recent study trip with the Department of Health and the OECD to the Netherlands to learn more about integrating care, and integrating rather than integrated being the key word. So in order to look at operational leadership competencies to deliver integrated care, it might be useful to consider what is integrated care. At its most basic, integrated care should be, or is, a simple idea. So combining parts so that they work to form a whole in order to optimize care and treatment. But as Lisa said, the process of integration to achieve better outcomes for people is very complex and difficult to describe. Classifications of integrated care include types, so organizational, professional, and functional. And then the breadth, so it could be horizontal, vertical, or virtual, or all three. And the degree of integration, so that continuing from linkages and coordination to full integration. And then processes, so including social and cultural integration, as well as structural and systemic integration. So when we look at clinical and service integration, we're looking at coordination of services and the integration of care in a single process across time, place, and discipline. Management and organisational processes to support integrated care occur at many levels and often at the same time. And differing local and national contexts can be highly influential in how receptive a system might be to support integrated care, and that continuous adaptation that is required over time. And that is an experience most of you probably have to date. Our learning from the Netherlands is that integration requires a significant culture shift to focus on overall population health, the bottom-up approach. So leaders must be able to think differently to address the wider determinants of health, and leaders need to embed the idea of supporting better health of the whole population into all roles. So the slide here shows the rainbow model of care, or as is known, the RMIC. And I know a lot of you are familiar with this as a conceptual model. It's also used in the Netherlands, and it places person-focused, population-based care as the guiding principle for achieving integration across the care continuum, with different integration processes playing interconnected roles on the macro level, so that's system integration, on the meso level, so organizational and professional integration, and then the micro level, so the clinical and the service and person integration that we've just heard about from Michelle and Veronica. So with the right balance then of functional integration, so human resources, finance, data sharing, and then normative integration. So examples of normative integration include motivation, shared cultural values, and trust. And that then ensures the connectivity between the levels. The Netherlands has also focused, similar to Sláinte Care, on primary care as the first contact, that first level of care philosophy underpinning service delivery, and also on the broad intersectoral collaboration. So next slide, please, Kira. Many of you are very familiar with the iceberg model. So this slide is from the International Foundation for Integrated Care, and it really demonstrates the complexity of competencies required by distinguishing the technical competencies we can see above the surface. So what we know and can do, and our skills and knowledge that are required. And those behavioral competencies below the surface. So the ability of leaders to understand what motivates, so those cultural factors, the deeply embedded values, behaviors and traditions, an understanding of how teams work, and the ability to build relationships, create urgency, and engage to enact change. So people, culture, politics, processes, and the ability to define why, what, and how connects people with a sense of shared purpose and ignites hearts and minds. And our next slide. So operational leadership for integrated care, it's very situational, and styles need to vary. Similarly to the Irish context, co-design is central to success in the Netherlands to date. And the learning we took away included the need for a very strong bottom-up, whole system leadership approach to population health, a commitment to prevention, and strong collective and adaptive leadership with competencies that include anticipation of the likely future needs, the articulation of the needs to build that collective understanding and support for action, adaptation, so there's continuous learning and adjustment, and then accountability, so transparency in terms of decision-making processes and openness to challenges and feedback. And before I hand over to Kira, as Michelle and Veronica said, and Lisa before them, the process of integration to achieve better outcomes is complex and it takes time. So thanks, Kira.
Thank you very much, Mary. That's really interesting and really good insight from the visits we've had and all the work you've done and a number of us have been doing. And I'm going to add here some thoughts on clinical leadership competencies and add that to the conversation, although I don't have a lot of time. And I just want to say by clinical leadership, I'm referring to clinicians and leadership. I'm talking about our nurses, our health and social care professionals and doctors. And my first slide looks at some integrated care for children and young people and comes from work that myself and colleagues have done in the last year, looking at integrated care internationally, looking for models that work, and also from our visit, as you mentioned, to the Netherlands, where they have developed that regional structure and an integrated care model. Now, we found no perfect system, but these are the ingredients that we were able to pull out from that work, the ingredients for success. And you can see how they reflect in the conversations we've had already today and in the work that you've described as well, Mary. So a shared consensus about the specific objectives of population health and integration is really important. Having a clear strategic framework in place, that sustained government commitment that Liam mentioned through Sláinte Care, but the importance too of local partnership, building trust, nurturing a collective attitude across the whole system, and really balancing that unified national efforts with local needs-based approaches. And then what I thought I'd do just over the next couple of slides is talk particularly about the competencies and what clinical leaders can bring to the world of integrated care. And this first slide is it's quite North American, but it does look at how clinicians develop skills. Not all of us are taught leadership skills in undergraduate um, college, but as we become clinical leaders, you can see that there are skill sets that can be delivered. You can see on an individual practitioner level down here that clinical is really important, that kind of ability to deliver what you're trained for. And then as you progress in leadership, maybe you become your need to develop your relationship skills, so those abilities to manage people, and that becomes more important. And then as you progress over up through maybe becoming a director or a clinical lead in your area, or maybe a healthcare manager for your area, or a clinical nurse manager, you become aware of the competing demands of external and internal forces, as well as those relationship pieces. And then you can see that as you build up towards becoming, and some of those listening today maybe will become CEOs of different leadership or of different healthcare areas, the clinical becomes a little less important, but really that huge relationship piece is there, that you become very business oriented and that your strategic abilities develop. I like this paper now from 2012. It's from the King's Fund, and it's a whole conglomeration of papers looking at leadership and engagement across the systems. And what they did is they commissioned different areas of research, and the one that I have highlighted here from Welburn really looks at how clinical leaders can contribute to engagement in change. And I think that's really important for the work we're doing across our integrated health areas and our regions today. So clinical leaders can go out of their way to make new connections. Their competencies, they have to have an open, inquiring mind, unconstrained by current horizons. Your ability to embrace change and flux, but be positive about the change, is really important. And to draw on and listen to as many perspectives as possible, to ensure that leadership and decision making are distributed across the system, and promote the importance of all of our values. And I have these links as well, are available afterwards. A more recent paper then in the BMJ shows that where clinical leaders make distinct contributions to integrated care, and this is about clinical leaders bringing their fellow clinicians into that partnership that Mary describes, and that's being able to construct a realistic and shared vision of integrated working to legitimize the proposed models of integration that we have, and really to promote that engagement and commitment to integration. That's going to be very important for our patients and our fellow workers, and to facilitate collaboration and the sharing of resources. I think it's a very whistle-stop tour of clinical leadership, but I was going to leave with this. So Don Berwick, who is known to many as a huge a component of leadership and integrated care, was president and CEO of the Institute for Healthcare Improvement, was a paediatrician, which I am myself as well. And when he was asked about healthcare, he said he thinks healthcare is more about love than about most other things. And he talked really about love and connection. And a very hot off the press study here from looking at what were the competencies and leadership that most succeeded throughout the recent COVID-19 pandemic. They focused on compassionate leadership and said compassionate leadership fosters a collaborative, caring, and kind environment. And I think at this time of change and opportunity that we have, and we want all of us to do our best for our patients and our families. And I think the work that we do as clinical leaders and as operational leaders like Mary, and working together, is to be compassionate and kind, to build bridges, and I think be patient with the system and work together. So that's me. Thank you.
Thank you very much. I'm joined now by Mary, Ciara, Emma and Lisa, and thank you for those contributions. Maybe first, Lisa, we'll go and see the feedback on the Menti if that's available to you. Do you want to share that with us?
Absolutely. Okay, so as you can see, we have some really strong, clear ideas of what integration means to us. I think there's over 165 responses, so thank you to everybody that has hit their responses in here. So some key words are really coming out: collaboration, person-centered, seamless care. And I suppose what this does, it shows us what integration really means to us in practice. So how do we work together across teams and services, putting people first at the heart of care in terms of person-centeredness? Are we making care seamless, holistic, and connected, and supporting each other to achieve shared outcomes? So it's a really good snapshot of our shared vision for integrated care. So I just wanted to thank you for all of your contributions, and it is available for download after the webinar. So thank you to everybody for that.
Thanks, and you can see the note there from saying that that will be available along with all the other content and the recording. So Ciara, I wonder, could I go to you? A question came up on the Q&A when we were going through the set pieces there. One question was from Catherine around integration with voluntary disability entities or providers. Is there anything you'd like to say about that in terms of this approach to integration?
I think, Liam, thank you for the question. And I think there's no integration without including all of our voluntary organisations as well. The integrated care is about the patient and the family and what's important to them, you know, from a day-to-day basis and living their best life. So absolutely, integration needs to include voluntary organizations. And I know we're working out, you know, the best platform for that across our integrated healthcare areas and regions.
And I guess the process is kind of blind to the organization structures. It's focused on the patient and service user in any event.
That's correct. And it's by starting with the patient and keeping them central that we're going to move on this journey. But it's going to take a little time, I think, to embed it, but we'll get there.
Yeah, thank you. And Mary, just on the use of the Sirocco tool, how would you see that in terms of actions on the outputs that arose? How would you see that being actioned and thinking about the outcomes and the posture team?
So thanks for the question, Liam. I think that Michelle and Vanessa described the posture team very well in terms of an integrated service and a new service. So it's working towards maturity. And you will have seen from the spider diagram that while they recognise they're very strong in some areas, but not in others, the Sirocco tool measures on a scale of 0 to 5. So what I'd be looking at is what are we nearing, you know, in terms of quick wins, 0 to 5? Are we at a 3 or at a 4? And what will take us to 5? But more importantly, because it's all about readiness for change, and it's all about that maturity to adopt integrated care and adopt and integrate the requirements for good practices. So your governance and your structure piece. So I'd be looking at those gaps. And I know a question came up in the Q&A section in terms of population. and service users. And the Menti tool is a self-assessment tool, and it's to be used by people who are involved in healthcare. But what you would be doing is taking the outputs of that. So that spider web that you saw. And because one of the very big things about being fully integrated is public support, political consensus, and stakeholder engagement. So you'd absolutely be focusing on that. And particularly, you know, I think Anne in the patient partnership identified that we don't do that so well. So that's exactly what you would be taking out at a ground level, bottom-up approach, working with your community in terms of making sure we're integrating well for wellness.
Yeah, thanks, Mary. And just a further question around the next 3 years for either yourself or Ciara in terms of how would you see this kind of approach supporting the work to be done around integrating of care over the next 3 years? I know there's more issues to consider. In fact, some of the questions raised queries about technology and connectivity and linkage, as was referenced in the presentation. But when you look forward 3 years, how do you see this kind of approach supporting what you're looking to achieve?
In terms of something like the Sirocco tool,
yeah,
I suppose what Lisa identified were there are a couple of tools at a couple of levels in an organisation or a system to be used. The Sirocco tool is definitely one for, I'm going to say, our frontline services in determining that maturity. So I think it's a very important tool to identify the maturity level. And then really, I suppose that has to be part of each region's strategic plan. For integrated and integrating care will include that strategic plan around the gaps for where we're at the moment. It is a tool that we used as part of a project with regard to workforce planning, but workforce planning not just being about numbers. And I know we're you know, in an era where people have concerns about capacity with regard to numbers, but it's a wider capacity piece in terms of, as Michelle and Vanessa described very well, capacity in terms of our service users and I suppose self-management. And that's really where we want to get to as well in terms of integrated care and a strategy for a well population.
Thank you very much. Emma, just to ask you, how did completing the evaluation as a team, how did that inform your service planning and delivery?
Again, we use it really as a reflective tool more so than an actual service planning tool, really. But again, you know, we were delighted to see that our biggest strength came out of the capacity building, because again, we would be very involved in collecting kind of qualitative data and again, trying to build capacity within our own team, and also, like Mary said, within the service users as well, and try and get their capacity up for developing their own health and well-being as well. Yeah. And our readiness to change with that 3 as well, which was great. And like Mary said, it'd be lovely to get that 3 up to a 5. But again, within the team, we would recognise that, you know, there are other limitations around that as well.
Yeah, and you flagged, and there were practical limitations, and some of them visible on your spider diagram. Has that helped in trying to address and move on with some of those? I did notice IT and funding were 2 of the ones that were closer to the
well, they're out of my control anyway, but unfortunately, but again, it would be, I suppose, when the IT piece comes down the line and again becomes integrated into primary care itself, that will be a really huge bonus for us, because again, on a very practical level, using shared files even within our own team has been a huge game changer for all team members. To have access to, you know, interventions done by another team member has been a wonderful. We get the verbal and we will have our discussions, but also to have it written is great. And also at the end of a service user's time with our team, they get a completed multidisciplinary report as well. And that's not done within any other service within primary care. So again, you know, it outlines interventions and it outlines future recommendations for that service user, again, to kind of increase their capacity for taking charge of their own wellness.
Thanks, Emma. And Mary, just going back to you, in terms of when you look at the acute community service provision and the need to join that up in the patient interests, do you see this being a key kind of approach and set of tools to support that, or how do you see that playing out in reality for you on the ground, given the senior nature of your post and the challenges you face?
Thanks, Liam. And I saw a similar question in somebody has put it in. I say it's somebody who knows me, because I think integrated care is the only way we can go, and integrating care, you know, provides a much better service for the public, and that's all of us actually. So just to say that, a tool like this will actually, you know, the whole idea of a tool like this is that it can be done from, so the Posture team did it as a team, sitting down together, you heard that described, but it can actually be done individually. So if you like, I always think of, if we're trying to move mountains, the patient or the service user is at the top of the mountain, and we're all trying very hard to get to the top of that mountain from different sides of the mountain. So if you think of the Sirocco tool being used by perhaps an acute team or part of an acute hospital team and a community team, you'd be looking to overlay that. You'd be looking at the cultural differences. You'd be looking at how we're, the breadth of our ambition, how we're empowering everybody to move, and really the removal of inhibitors. And that's very, very much the biggest thing. And I think, you know, they do say culture trumps strategy, and I think that's absolutely right. Communication, getting to understand people. And as I said earlier, you know, those deeply embedded values, it's actually tackling all of that and attitudes towards integrating care that are important. And really that's part of my aim now for the next few, say 3 years, but hopefully longer. Thanks, Lee.
Thanks, Mary. Yeah, no, it's great to see your commitment to that. I know that the road ahead is long and hard, but it's vital work. Just maybe, Lisa, to finish up with you, I'm conscious we're approaching 2 o'clock. You referenced that tools are being adopted, I think, in the Irish context. Can you say more about that and when they'll be available?
Yes, I'm really conscious that today was a very high level whistle stop tour of 4 of the tools that we're currently working on. Sirocco there has been beautifully given an overview from the Posture team, and that's more, I suppose, targeted to systems level, but the other 3 tools are more focused on different levels. So from a frontline level, in terms of the iPad, is more to do with interdisciplinary working. The Sky Logic model is more about how do teams come together and look at planning for integrated care and shared outcomes, and then stepping up to the place is more targeted to leaders to start looking at those reflective conversations around how do they share services, how do they look at shared outcomes. So the tools are pitched to different levels in the system, and as you say, Liam, they need to be adapted to the Irish healthcare context. That's the current work that we're doing at the minute. So we're hoping in the next few months we will have those tools available for download, and we'll also have resources like workshops and different kind of guidance documents to really help services and teams kind of apply those in practice. So just to say around the Sirocco tool, it is an online platform. It's a fantastic tool, but we do need to have some careful consideration around the data privacy and data protection elements as part of that. So that's another element that we're currently working on.
Yeah. Thanks very much, Lisa. So I'm conscious we're at 2 o'clock just about now, so we'll close down. But just to note, the presentations were put up in the chat, and there are a lot of links in the chat, which I hope will work for you. And the video and all the content will be available later. So thanks for dialing in, and we'll end it there. Thanks very much.
Thank you.